Hello, welcome to Chronic Illness. This video and the ones that follow are an in-depth look at the various medications used to treat restless leg syndrome. They're a follow-up to my first video on RLS, which gave an overview of the condition, plus the various treatments for it. If you haven't watched it, please go back and watch that one first, because it's got a lot of background information that will help you to understand what I'm saying in this video. It's linked below. I'm filming the medications content all at once, but it's quite long, so I'll break it into several videos, which will flow on from one another, so definitely watch them in chronological order. In the first video, I'm going to go over the biological causes of the condition and explain the key terms you'll need to know. Then I'll go over the medication options. In the second video, I'll give you the general advice for use of RLS meds and explain the treatment process for 3 different categories of RLS. In the final video, I'll tell you about the RLS medications I've been on for those who'd like to hear my personal experience with them. Now, I know long intros and disclaimers are boring, but because I'm talking about medications, it's very important that I include a proper one here. Okay, these videos are not medical advice. I'm not telling you how you should treat your RLS. That's between you and your doctor. I have a biology degree, but I am not a doctor. I'm just someone who is good at research and has a platform on the internet. All I'm doing here is reading and summarizing the scientific literature written by the experts in the field and translating it to you via these videos. I'm just the messenger. This is not advice from me personally, it's what's advised in the scientific articles. My goal is for you to be aware of the various medications available and their pros and cons. You should also know that this is all general information. Not all of these options will work for all people. We all have genetic differences and different medical histories and needs, so a medication that works for others may not work for you and vice versa. You have to tailor your treatment to your individual needs. Trigger warning, this video contains discussion of addiction and addictive substances. Now, I can't just jump into the medications right away because RLS is a very complicated condition, and in order to explain the medications to you, I first need to explain some of the biology behind the condition and the various terms involved because there's a bit of medical jargon. This section will get a bit technical, but it's worth a listen because knowing the science of RLS will allow you to understand how the medications affect your body and help you choose the best one for your needs. Plus, I think there's power in just understanding your condition better, understanding what the medications are doing to your body, you know? So I left the science in. The first thing you need to know about restless leg syndrome is that it involves a problem with dopamine transmission in the central nervous system, which is the brain and spinal cord. Dopamine is a hormone and neurotransmitter that is involved in many crucial functions in the body, including motor control, that's movement, behavior and executive functions, regulation of mood, attention and motivation, and regulation of the body's reward system, as dopamine is released when we do something pleasurable. Dopamine is extremely important, and having too much or too little of it, or having problems in the way it works in your body, can cause very serious illness. For example, Parkinson's disease is caused by a loss of dopamine-producing neurons in certain brain regions. ADHD is also a kind of dopamine deficiency disorder, but too much dopamine also causes problems. Excessive dopamine is responsible for the hallucinations and delusions involved with psychosis and schizophrenia, which will become relevant when we get to medications. And of course, faulty dopamine transmission in the central nervous system is thought to be the primary cause of restless leg syndrome. Scientists still don't understand exactly what causes RLS and how it works, but we know it's more complicated than a simple dopamine deficiency or excess, since with RLS you can have too much dopamine in some cell or brain areas, but not enough in others. Paulus and Trenkwalder 2006 write, "Dopaminergic drugs must therefore improve RLS symptoms by modulating a complex neural network and not by adjusting a specific dopamine deficit." This means that RLS medications work by adjusting the way your body uses dopamine in multifaceted ways. I'll explain the aspects of dopamine function that relate to medications, but keep in mind what I'm giving you is a simplified version. Let's go over some jargon you need to know. When I use the word dopaminergic, that just refers to any biochemical process or medication that involves dopamine. It's a general term that tells you dopamine is involved somehow. You also need to know the term receptor. A receptor is a site that another molecule acts on, in this case dopamine. It's sort of the receiver of dopamine, like a lock and key. You should also know the term agonist. An agonist is a substance that does the same thing as another substance. So a dopamine agonist is a substance that acts like dopamine in the body. Your body basically thinks the dopamine agonist is real dopamine and uses it the way it would real dopamine, as opposed to an antagonist, which blocks the action of that substance. Now let's have a look at what's happening with dopamine in the nervous system and how certain medications remedy this or worsen it, keeping in mind that this is just one mechanism behind RLS symptoms. There are several types of dopamine receptors, D1, D2, D3, D5, etc. It's the balance between the activities of these receptors that's responsible for normal movement and sensation. Normal function requires a synergistic interaction between D1 and D2 or D1 and D3 receptors. In healthy people, these receptor types are in the correct ratio, but in RLS, they can be out of whack, causing receptor stimulation to be unbalanced. Stimulation of the D2 receptors is thought to be what provides relief from the pain and restless feeling, while stimulation of D1 receptors tends to worsen symptoms. People with RLS may have too many D1 receptors and too few D2 receptors in certain areas of their central nervous system, and this is thought to be the cause of the restless sensation and urge to move in RLS, as well as the jerky limb movements that also commonly occur. There are dopaminergic neurons, or nerve cells, in your central nervous system called A11 neurons. Dopamine is released at the junctions between these neurons. A normal person without RLS releases just the right amount of dopamine, but in someone with RLS, slightly less dopamine is released and you get the RLS symptoms. For this reason, many drugs that treat RLS are comprised of dopamine or dopamine agonists. These dopaminergic medications cause the neurons to release more dopamine each time they fire, thus restoring normal function and relieving the symptoms of RLS. But too much dopamine also causes RLS symptoms. So there's this Goldilocks zone where you have just the right amount of dopamine released. On a graph, this is a U-shaped curve, where too much or too little dopamine in the frontal cortex will cause RLS symptoms. This is important to understand because certain RLS medications can actually exacerbate restless leg syndrome and make the condition more severe. This process is called augmentation, and it's something that doctors and patients should be aware of. Augmentation refers to a drug-induced worsening of restless leg syndrome. What happens is the medication relieves the symptoms in the short term, but long term it causes the condition to be even worse than it was before you started treatment. This worsening of symptoms includes greater severity of sensations and earlier onset of symptoms. So if your RLS usually comes on around 8 p.m, it might start at 6 p.m. or 4 p.m. The symptoms may also spread to other parts of your body, like your arms and torso. Augmentation is an RLS sufferer's worst nightmare, yet most patients aren't aware of it, and many doctors aren't even aware of it. It's the dopaminergic meds that cause augmentation, but when the doctor doesn't realize this, they will usually increase the dose of the medication in response to worsening symptoms, which causes symptoms to increase. Then you increase the dosage until the patient is stuck in a vicious cycle that can lead to a massive reduction in quality of life and serious mental health impacts. One expert described this dose escalation as clinicians attempting to put out the fire of RLS with gasoline. Clearly, we need more awareness of augmentation. I'll quickly mention that augmented RLS can be treated, so don't despair if that's already happened to you. I'll explain the treatment of augmentation in the next video. In terms of the biological mechanism of augmentation, the leading hypothesis is that it's due to the downregulation of D2 receptors. As I said earlier, RLS involves unbalanced stimulation of the different dopamine receptor types. The excessive dopamine that comes with too much dopaminergic medication causes the body to downregulate or get rid of some of its D2 receptors, so you have too few of them. But it keeps the D1 receptors in action, so your ratio of D2 to D1 receptors is off. This causes symptoms to increase, aka augmentation. There are other proposed mechanisms contributing to both the initial RLS symptoms and the process of augmentation, but it's not necessary for me to go into detail about those, so I'll leave it there. We're nearly finished the science section. We just need to look at one last thing, and that is iron. Iron plays a crucial role in brain processes, including those involved with RLS. People with RLS have low iron levels in certain brain regions. In fact, a lack of iron in the brain is one of the mechanisms behind RLS. Unfortunately, you can have adequate iron in your bloodstream, but be deficient in iron in your brain. This means not enough iron is crossing the blood-brain barrier, that is, passing from the blood into the brain. At this stage, there's no medical treatment that can force more of that serum iron into your brain tissue. What's guaranteed to cause low brain iron is iron deficiency anemia, because if you don't have enough iron in your body overall, you're not going to have enough iron in your brain. In fact, we know that iron deficiency causes restless leg syndrome. Let me say that again. Iron deficiency causes restless leg syndrome. For those whose RLS is caused by a deficiency, the lower your iron, the worse your RLS symptoms will generally be. There are a few hypotheses about why this is. Iron is also a cofactor or assistant in dopamine production. So less iron means less dopamine can be produced per unit time. Oxygen is vital for all tissues, and oxygen transport is also dependent on iron. So when brain tissues are low in iron, they can become hypoxic or low in oxygen, and some of the biochemical processes in those areas are impaired. Iron deficiency also reduces dopamine transporter density and function in some brain regions, and reduces D2 receptors in the striatum, which triggers augmentation. That one's worth repeating too. Iron deficiency can cause and/or exacerbate augmentation of restless leg syndrome. Augmentation is magnified when the patient is in an iron deficient state. Iron deficiency can also make previously effective medications stop working properly. Lastly, myelin synthesis is also dependent on iron, so those with low iron have reduced myelin around their nerves. Myelin is a protective sheath around nerve cells that helps them fire correctly, so we want that myelin intact for healthy neurological function. All of this means that A, iron levels must be checked and, if necessary, administered in all patients with RLS, and B, dopaminergic therapies, which are the ones that cause augmentation, should not be used or used very cautiously in RLS patients with an underlying iron deficiency. Now that we have some background knowledge of the condition, we can start looking at the medications used to treat restless leg syndrome. In this section, I'm going to run through the different classes of medications and the individual meds in those classes. But after that, I'll talk about general treatment principles for RLS, including medications. So even if you're only interested in learning about one category of meds, make sure you also watch the section on general principles, because there's important information there about do's and don'ts when taking meds for RLS. It'll be in the video that follows this one. Lastly, I'll mention when I've been on a certain medication, but I'll leave the details of my experience for the final video and talk about them all together. I'm going to go over iron first. It could technically be considered a supplement rather than a conventional medication, but I'm including it here because it does factor into the pharmacological treatment of RLS. For a subset of RLS patients, increasing their iron levels works and works well. Those whose RLS is caused by iron deficiency anemia may experience complete relief of their symptoms when their deficiency is corrected. Others will not see an improvement, but you won't know unless you investigate. Every single RLS patient, no matter the type or stage of their condition, should have their iron checked, regardless of whether or not they show other signs of iron deficiency. A full iron screen should be done. This includes serum iron, ferritin, total iron binding capacity, and percentage transferrin saturation. The blood test should be done in the early morning on an empty stomach, with iron supplements and red meat discontinued for 24 hours prior to the test, as this can skew the results. If serum ferritin concentration is 75 micrograms per litre or less, and transferrin saturation is less than 45%, oral iron supplements and vitamin C should be taken. Infection or inflammation can cause serum ferritin to be higher than normal, so the lower threshold of less than 20% transferrin saturation should be used to adjust for that skew. Once serum ferritin is greater than 100 micrograms per litre, you can stop supplementation. There are some situations where oral iron won't be effective, and it's better to do an iron infusion, which is an intravenous delivery of iron. This is the case for patients who can't tolerate oral iron, who have impaired absorption due to a condition affecting the gastrointestinal system, or when rapid administration of iron is needed. An iron infusion should also be used when RLS symptoms or iron levels fail to improve after oral supplementation. In fact, if RLS is severe or augmented, an infusion should be the first line of iron therapy, especially if serum ferritin is less than 100 micrograms per litre. This is because the higher your iron levels, the less iron your body will absorb when you take it orally. So you could have a situation where, because your blood iron is adequate for general functioning, your body won't hold on to the extra iron you're getting from supplements or diet. It will allow it to pass out as waste. But when it comes to treating RLS, we need iron levels to be not just okay, but on the high side of the normal range, in which case you need an intravenous delivery method. As long as you don't exceed the safe limit for iron, you can push those levels higher using an infusion. There are a few formulations of iron available. Your doctor can advise you on the best one for you. Be patient, it can take 4 to 6 weeks for iron therapy to take full effect. There are also a few other considerations when taking iron, but I've already covered them in my first RLS video, as well as a separate video on iron supplements. So definitely check those two out, linked below. One last thing, someone said in the comments of my first video that their RLS went away when they got their vitamin B12 levels up, since they were deficient in B12 and didn't realize it. And I can't believe I forgot to mention this, because it's very important for 2 reasons. B12 is crucial for neurological function. Substandard B12 causes neurological problems, which can be very serious when levels are extremely low. Now, none of the papers I read mentioned B12 in relation to RLS, but since we know that B12 is vital for neurological health and RLS is a neurological disorder, it's plausible that low B12 could exacerbate RLS. Secondly, B12 deficiency can cause anemia. Anemia is when your body doesn't have enough healthy red blood cells, and B12 is required for production of new blood cells. So make sure you get those B12 levels up if they're low. See my video on how to supplement with B12 and iron, linked below. Unfortunately, many patients fail to see an improvement from taking iron and B12 and will need to try other prescription medications. In terms of conventional medications, I'm starting with the dopaminergic ones because for a long time they were considered the frontline drugs of choice to treat restless leg syndrome. So they're the most widely prescribed. The dopaminergic meds are Levodopa and the dopamine agonists. It sounds like a prog rock band. Levodopa and the agonists. I'd listen to that. The first one we'll look at is Levodopa. Levodopa is basically just dopamine. Well, it's the precursor to dopamine, so when you take Levodopa, your body converts it into true dopamine. This drug was developed to treat Parkinson's disease, but it also relieves RLS, at least in the short term. Levodopa is usually combined with something called carbidopa. Carbidopa just prevents your body from converting the Levodopa into dopamine too early. To be effective for RLS, the dopamine has to get into the central nervous system, not just the peripheral nervous system. Levodopa can cross the blood-brain barrier, but carbidopa can't. So the carbidopa blocks dopamine conversion in the periphery of your body, but allows it in the central nervous system where it's needed. This means a much lower dose of levodopa is required, which reduces side effects. So it's pretty clever, honestly. Problem is, levodopa is very prone to causing augmentation. Some studies found a 60 to 80% occurrence of augmentation in patients taking levodopa long term. And it's a real shame because levodopa works really well in the short term and is generally well tolerated by patients as it doesn't have many side effects. Nausea is the main side effect that can occur, but you generally don't get the really serious side effects that some of the other RLS meds can cause. Still, levodopa can be used successfully in patients whose RLS is intermittent or temporary, which I will explain in more detail later. For maximal absorption, levodopa should not be taken with high protein foods. I have been on levodopa, carbidopa before. The next class of drugs is the dopamine agonists, or DAs for short. As I said earlier, dopamine agonists do basically the same thing as dopamine. So because they act like dopamine in the body, DAs are also prone to causing augmentation. They don't do it quite so quickly and strongly as levodopa, but augmentation has been found to occur in 5 to 10% of DA-treated patients per year of treatment, which obviously compounds over time. While augmentation doesn't happen for everyone, it becomes highly likely when you've been on a dopamine agonist for many years. In fact, 50 to 70% of patients using DAs develop augmentation over 10 years. That's a lot. And as RLS is usually a lifetime thing, you have to think about your treatment in terms of years to decades. Now, augmentation is dose dependent. Higher doses will cause faster and more severe worsening of RLS, so it's important to keep doses as low as possible. As I said earlier, clinicians who don't realize this are unknowingly making their patients worse. An estimated 20% of RLS patients in the US are prescribed doses of DAs that are above the maximum RDA recommended level, and the prevalence of augmentation in patients currently on DAs is thought to be 30 to 50%. Again, we desperately need more awareness of augmentation. The dopamine agonists used to treat RLS are pramipexole or Mirapex, ropinirole or Requip, or rotigotine, Nupro. These are known as ergot dopamine agonists. Pramipexole and ropinirole are oral tablets. They're relatively short-acting, so they have a faster onset but a shorter duration. This means that a single dose might not cover you for a whole night. It can be better to split the dose in two or use rotigotine. Rotigotine is a patch that sticks onto your skin, and it's a long-acting agent, so it can be useful for patients whose symptoms extend during the day. The only problem with long-acting agents is that they can mask the early signs of augmentation. So you might not notice that your RLS is occurring earlier in the day because it's masked by the continuous nature of the medication that the patch provides. As I said, make sure you're not iron deficient before you start dopamine therapy to reduce the likelihood of augmentation. Common side effects of dopamine agonists are daytime sleepiness, nausea, headaches, and fatigue. Some people experience skin irritation from the rotigotine patch, so if you've got sensitive skin, that could be an issue to consider. A potentially serious side effect of DAs can be the development of an impulse control disorder, like compulsive gambling or overeating. Therefore, DAs are not recommended for those with a history of substance abuse or behavioural addictions. As with all meds, you're not guaranteed to experience side effects, and sometimes they disappear once your body adjusts to the medications. These DAs are still the recommended first-line treatment for patients with conditions that may be exacerbated by the other classes of RLS meds. There is another type of DAs called non-ergots, but these are no longer recommended due to potentially very serious side effects. The two main ones are pergolide and cabergoline, but these are not advised. The next class of drugs for RLS are called alpha-2 delta calcium channel ligands, or A2Ds, alpha-2 deltas for short. These are now considered the first-line agents for treatment of chronic RLS because they don't cause augmentation. The A2Ds used for RLS are gabapentin or Neurontin, gabapentin in carbol, Horizont, and pregabalin or Lyrica. I've been on pregabalin, by the way. Gabapentin in carbol is a formulation that becomes gabapentin in the body. It's just formulated that way to improve its performance inside your body, but it works the same as gabapentin. Alpha-2 deltas have been shown in clinical trials to be highly effective at relieving restless leg syndrome. They also have other actions in the body which should be considered when deciding which medication is right for you. The A2Ds are anticonvulsants, that means they treat epilepsy and seizures, and also analgesics or painkillers, which are particularly good for neuropathic pain like fibromyalgia pain. They do tend to have a sedating effect, so they can also help you sleep. So if you have any of those problems, you might be able to kill two birds with one stone with an A2D. While A2Ds are usually very effective against RLS, the side effects can be too much for some people. Common side effects include sleepiness, dizziness, nausea, and weight gain. Other effects are gait instability and problems with memory. For these reasons, A2Ds are not recommended for those with cognitive impairment, obesity and overweight, or who are at risk of falls. Because of the sedating action, A2Ds can cause breathing problems in susceptible people or those already on CNS depressants. For these people, the dopamine agonists would be preferred. Less common classes of drugs used for RLS are anti-epileptics and benzodiazepines. Of the anti-epileptics, carbamazepine or Tegretol has been found to help RLS, although it does have some side effects which makes A2Ds preferred. I was on carbamazepine for a very short time. As it turns out, I am severely allergic to it. I'm now on lamotrigine for my epilepsy and I find it much better. Lamotrigine can be useful for neuropathic symptoms and it's also a mood stabilizer. The doses of anti-epileptics for RLS are lower than those used to treat epilepsy. Benzodiazepines or benzos can be helpful for intermittent RLS. Benzos are sedating medications used for short-term relief of anxiety, insomnia, and as muscle relaxants. Valium or diazepam is a common benzo that you've probably heard of, but clonazepam or Klonopin is the one usually prescribed for RLS. These drugs are effective short-term, however, benzos are highly chemically addictive, which is what happened to me when I was put on one. Your body can develop a chemical dependence on benzos in just 2 weeks of daily use. You also become tolerant to them over time, so you need to keep increasing the dosage to get the effects. So benzos can be effective, but they have a strong potential for abuse, so must be administered very cautiously and are not suitable for ongoing daily use. The last category of RLS drugs are the opioids. These medications are powerful painkillers, but they're also highly effective against restless leg syndrome, which is because the opioid systems in our bodies interact with dopaminergic systems. Because of the risk of addiction and misuse, opioids are generally not prescribed for RLS except in severe or augmented cases, and where all previous treatments are not working or not tolerable to the patient. So you have to have tried the dopamine agonists and the alpha-2 deltas first, and you would only trial an opiate if these meds don't work, or they're causing augmentation, or they cause unacceptable or dangerous side effects. You would also be required to try all the non-pharmacological techniques for relieving RLS and reducing insomnia. See my first RLS video for more details. There are some differences in the way opioids are used to treat RLS as compared to acute or chronic pain conditions. Firstly, the doses used for RLS are much lower than those used for pain, which is good because it reduces the risk of addiction and abuse and reduces the side effects. The type of opioid also differs. You've probably heard of the lower potency opioids like codeine and tramadol, but these more short-acting drugs are more useful for treatment of pain. They can be used for RLS, especially when symptoms are confined to a short window of time. That way you can get away with lower doses. But generally, people with severe RLS experience daytime symptoms too, so the longer-acting controlled release drugs are preferred. While controlled release morphine and hydrocodone are options, the best studied and most recommended opioids for RLS are methadone and extended release oxycodone. Buprenorphine is another long-acting option. From the papers I've read, methadone seems to be the one most recommended, but oxycodone has also been shown to be successful in trials. And not just in the short term. Opioids don't cause augmentation in RLS, and unlike their use as painkillers or as illicit drugs to give you a high, they continue to work long term. You don't get the tolerance and the need for higher and higher doses when treating RLS. The same dose can treat the condition for years with no need for an increase, or perhaps only a slight increase after a few years. Methadone in particular has less potential for chemical tolerance than other opioids, which means it has lower potential for abuse. As for side effects, opioids can cause constipation, nausea, and sleepiness. Since they are CNS depressants, they can also worsen sleep apnea, so they may pose a risk to patients with that condition or those with breathing difficulties. They should not be taken at the same time as benzodiazepines or alcohol. Constipation is probably the most persistent side effect and is dose dependent, but it can be reduced or managed by staying hydrated and eating a healthy diet with plenty of fibre and the use of laxatives and stool softeners. Oxycodone is also often administered in combination with naloxone, as this reduces constipation. Now, we need to talk about the opioid crisis. In case you're not familiar with this, it refers to the epidemic of opioid addiction and overdose that was basically caused and fueled by pharmaceutical companies and irresponsible doctors pushing high doses of dangerously potent opioids onto patients, which led to them becoming addicted in large numbers. Which of course led to many deaths, crime waves, and general devastation of whole communities. Also, these companies and their executives could make more money. I hate those monsters, for this reason and for another reason. The opioid crisis has made it very difficult for patients who genuinely need opioids to get them. Doctors are so fearful and reluctant to prescribe them that they end up withholding pain relief from people whose pain or other symptoms justify these medications and who will use them responsibly. This is something I've experienced almost my whole adult life. Most doctors I've seen have failed to take my pain seriously. They brush me off, they tell me my pain isn't that bad, they tell me to just take paracetamol, which does jack all. When you have an invisible illness like ME/CFS or even restless leg syndrome, people write you off, including doctors. They tell you you're faking it, they tell you you don't look sick, it can't be that bad, and other gaslighty statements. This is doubly true if you're young and if you're female. Pain in females is consistently assessed as being lower than the same conditions and symptoms seen in men. We have mountains of evidence for this in the medical literature, and my female friends and I have experienced this firsthand on many occasions. Women's pain and the pain of those with invisible illnesses is not taken seriously, and desperately needed pain medications are unjustifiably withheld, especially because when you have a chronic condition, you're used to being in pain. So you can be in a lot of pain, but from the outside, it doesn't show. You're that good at hiding it. And even when it does show, they accuse you of faking it. They either think you're just being dramatic or it's a drug-seeking tactic. I have never had any substance use disorders, and I've always used my meds responsibly and minimally whenever possible. Yet I have been denied pain meds in the past, which actually led me to take more dangerous combinations of meds just to get some relief from the symptoms of pain and of the insomnia caused by it, and relief from restless leg syndrome as well. That's one of the things that I couldn't get treated properly. And this is often the case with restless leg syndrome. Many doctors have never experienced RLS, so they don't understand how debilitating and torturous the condition is. So they might be reluctant to prescribe opioids to treat RLS. I want to share some quotes from some of the papers I read for this video, which come from some of the world's leading experts in the field. Silber et al. 2021 write, "Opioids are highly effective in the management of refractory RLS, reducing daytime tiredness and improving sleep and quality of life, and thus should not be withheld from appropriately screened patients because of a fear of potential development of tolerance or dependence. When opioids are used appropriately for RLS, escalation of dose is uncommon and misuse is infrequent in the absence of a history of substance abuse." On the opioid crisis, Silber et al. 2018 write, "As long as reasonable precautions are taken, this should not deter physicians from prescribing medications necessary for the health of their patients. Refractory RLS can be a devastating condition, resulting in profound insomnia, suicidal depression, and severely compromised quality of life. Nevertheless, prescribers should act responsibly with an understanding of the opioid epidemic afflicting the United States and the legal requirements of individual states," which of course goes for Australia and any other country. Please don't think I'm pushing opioids, I'm not. These medications can be very dangerous. They are chemically addictive and potentially fatal when misused. They can destroy lives, families, and whole communities. They do need to be highly regulated and only prescribed when necessary and safe. I am not advocating that doctors prescribe them willy-nilly to anyone who thinks they need them or anyone who has pain. The opioid crisis is real and has caused immeasurable damage, but the pendulum shouldn't swing too far in the other direction. We shouldn't withhold potentially very effective and life-changing medications from those who will use them responsibly. My philosophy is that, like any drug, opioids are a tool that can be used for good or bad. They can cause great harm or great benefit, but it needs to be done right. Experts recommend the following precautions should be taken before opioids are prescribed for restless leg syndrome. Of course, non-pharmaceutical techniques and non-opioid medications should be tried first. The opioid of choice should be tailored to the patient's individual needs, considering their unique medical history. Briefly, the sources I've read recommend questioning patients to screen for a history of misuse or high potential for misuse. Extra controls need to be put around high-risk patients. The prescriber must inform the patient about the potential for addiction, as well as any risks or side effects they might experience, and an opioid contract should be signed. Opioid meds should be administered from a single provider. Treatment should start with the lowest dose and be increased slowly until the desired effect has been achieved. Regular follow-ups and monitoring are a must. That concludes the section on medication types. For information on how these meds are used for RLS, stay tuned for my next video. As I have put a lot of work into this series, I'd love it if you could give this video a thumbs up, share or comment, and consider subscribing to my channel. And I'll see you in the next one. Levodopa and the agonists. Yeah.